Hello and welcome to our evening for focusing on hiking and walking. I'm Fiona Roach. I'm the General Manager here in the Sports Surgery Clinic. So the Sports Surgery Clinic, for any of you that don't know us, is in Santry, and it's probably just about 10 minutes from Dublin Airport, just off the M50 and the M1. And we are now UPMC Sports Surgery Clinic, as we're now part of a group which also has three other hospitals, one in Waterford, which is the Whitfield, one in Kilkenny, Orthopaedic, and one in Clane as well. And we have numerous sports medicine centres around the country. Also, for here from the Sports Surgery Clinic, we look really only after orthopaedics and musculoskeletal work. So things like hip and knee replacement, any surgery relating to your hand, your elbow, your spine, the hip and the knee as well. Now, tonight we've got two speakers. We've got Mr. Andrew Hughes, and Andrew is one of our orthopaedic hip and knee surgeons. Andrew's going to talk first. We're going to show a presentation, and then Andrew will join us live for a Q&A. So you'll see the tabs there for ask a question. So please, if you want to ask a question, please go onto that tab and ask a question. There are some other tabs there as well about future events. Also, if you need to ask a question, that'll go through to our GP line. There's another tab there about health screening. We've just set up a new health screening service in Swords. So if anyone's interested in any health screening and health and fitness screening, please go on there and we'll come back to you as well with any questions you may have. And one other tab is also about our VHI pathway. So I'm going to introduce Andrew now, and he will join us afterwards for the Q&A. Thank you.
Good evening. Andrew Hughes is my name, hip and knee surgeon from UPMC Sports Surgery Clinic, and many thanks for the opportunity to speak to you this evening on hip and knee pain in hill walking and hiking. Hikers get hip and knee pain from mechanical overload of their hip and knee structures due to repetitive loading stresses of the tendons, the cartilage, and the joints in the hip and the knee. Uneven terrain demands stability from the hip and knee muscles, and unfortunately, something as small as an inadequate warm-up or an unlucky step can put a hiker or a hill walker at risk of injury. Forces walking uphill versus downhill differ. Walking uphill, there's a particular pinch on the structures at the front of the hip joint. There's friction between the iliotibial band, the large fascia on the outside of your thigh, and the bursa on the side of your hip joint. And the load goes through the knee quite extensively from a flexed or bent position as you bring yourself up the hill. Going downhill, 4 to 8 times your body weight can go through your kneecap or your patellofemoral joint. These forces peak as your heel touches the ground or the heel strike component of your gait cycle. And the quadriceps muscles are lengthening but also contracting at the same time. We call it an eccentric contraction, and this controls your descent. And unfortunately, eccentric loading of a muscle or a tendon puts it at risk of injury. The tendons and cartilage around the hip and knee joints can succumb to overuse injury mechanisms whereby the load exceeds the tissue's capacity to heal from repetitive microtraumas. And these microtraumas can accumulate, particularly if there's insufficient recovery between hikes or a particularly long hike. Weak muscles can also transfer stress to otherwise passive structures and put these areas of succumbing to these microtraumatic episodes. It's important when you have pain around the hip or the knee to understand what we as physicians or surgeons look at to determine what the cause of the pain is. So some of the terminology we use is lateral, which means the outside of the hip, the thigh, the knee. Medial, which would be along the inside or kind of radiating from the groin. Anterior is at the front, posterior is at the back, and then oftentimes to distinguish between particular pathologies or injuries, we want to know is the pain focal, is it pinpoint, or is it diffuse? Is it over a wider area? And this can help us distinguish particularly from bursitis versus an iliotibial band syndrome, which I'll come to shortly. So pain in the groin could be femoroacetabular impingement or arthritis in the hip joint. Pain in the lateral hip could be gluteal tendinopathy or inflammation of the tendons in the outside of the hip, or it could be bursitis, which is inflammation of the shock absorber. Pain radiating down the lateral thigh into the lateral knee could be iliotibial band syndrome, which is often associated with gluteal tendinopathy and or bursitis. Pain at the front of the knee could be patellofemoral pain syndrome or an issue with the back of the kneecap. Pain below the kneecap can be patellar tendonitis, where there's an inflammation of the tendon where it attaches to the underside of the patella. And medial or inside the knee or kind of diffuse knee pain could be related to knee arthritis that's come on over time. So the common hip problems that affect hikers most notably could be femoroacetabular impingement, which arises from abnormal contact between the ball and the socket within the hip joint. So you might hear terms like a pincer lesion or a cam lesion or mixed FAI or mixed impingement, and these can be seen in the diagram on the right hand side. This can cause groin pain, especially on inclines or after prolonged activity that involve hip flexion, so bringing your knee up over your hip. You can be stiff after rest or stiff in the mornings. You can have discomfort with prolonged sitting as you sit in a seated position with your knees up. This impinging bone can lie in contact with each other, either on the ball side or the socket side of the joint, and cause a deep-seated groin discomfort. And there can be clicking or catching within the hip or the hip joint or the groin, particularly if the labrum is torn, which is the shock absorber within the hip. Diagnosing an FAI really involves a clinical examination with a physician or a surgeon or your GP. X-rays are the gold standard of investigation to see is there abnormal bone, and an MRI to look at the cartilage and the labrum in the hip. I would advise seeking help if you have sharp pain in your groin that persists despite rest. And the treatment involves activity modification, avoiding hip flexion, physiotherapy to strengthen your hip and your core, improving the strength of the rotators deep within your hip, working on improving the lateral control of the hip or the gluteal tendon strength around your hip. A hip injection of either corticosteroid or platelet-rich plasma can reduce inflammation, improve the ability of micro tears to heal, and allow you to engage your rehabilitation pain-free. And if all conservative options fail, then you may benefit from hip arthroscopic surgery or a camera surgery where we go into the joint with long, fine instruments, shave down the abnormal bone that's causing issues, and repair the labrum. Gluteal tendinopathy or gluteal tendonitis is inflammation or irritation or degeneration of the hip tendons on the outer or lateral aspect of the femur. The pain is on the lateral side of your hip. It can worsen on stairs or hills. And if you have coexisting bursitis, you can have pain lying on that side at night. Weakness or discomfort can also be noticed when standing on one leg, and you can feel unstable or as if you're about to fall when you are walking, particularly coming downhill if you have gluteal tendinopathy. Again, it's a clinical diagnosis, but that would need to be confirmed with either an ultrasound or usually an MRI of the affected hip. I would advise seeking help if walking or climbing stairs is particularly difficult, and if the pain progresses such that it's affecting your sleep quality, particularly when lying on that affected side. Treatment physiotherapy is highly effective. I would advise avoiding crossing your legs or side lying on the affected hip to reduce the amount of pain that you're experiencing. A graduated strengthening program with a physiotherapist, progressive hip strengthening, particularly side lying leg lifts, and single leg stance progression as per the guidance of a chartered physiotherapist. Greater trochanteric bursitis then can be inflammation of the fluid-filled cushion or the shock absorber on the outer side of the hip bone, which lies in close proximity to the gluteal tendons. So this really gives you that point tenderness on the outside or lateral aspect of your hip. It can be a constant dull ache. It can really affect your pain levels and increase if you lie on that affected side, and it often coexists with tendonitis of the gluteal or abductor tendons, plus or minus iliotibial band tightness, because that can push the greater trochanteric bursa in against the bone as you walk. Diagnosis for greater trochanteric bursitis is clinical examination. It's your point tender over that particular spot, and again that can be diagnosed further or confirmed with ultrasound or more commonly an MRI in these days. Again, I would recommend seeking help if climbing stairs is particularly difficult and if you're having trouble sleeping as you cannot lie on the affected side. I would rest, ice, and take anti-inflammatories for greater trochanteric bursitis, physiotherapy to progressively start loading the gluteal tendons, which will take the pressure off the greater trochanteric bursa, and a corticosteroid injection or a steroid injection into that site of maximal tenderness can be very helpful if the pain is severe. If gluteal tendinopathy and GT bursitis coexist, A progressive load-based physiotherapy-led rehabilitation program can be very effective, and platelet-rich plasma injections have been shown to encourage healing of the micro tears within the tendon and encourage all of this to settle down. Iliotibial band syndrome then is tightness of this big fascia band that runs down the lateral side of your knee. And this can push the greater trochanteric bursa against the bone and really inflame your bursa as you're walking. You can get sharp lateral hip, thigh, knee pain during repetitive hip flexion or bending of the hip. The pain typically starts after a consistent distance every time, but again, that can start to worsen as that distance comes down with progression. You would be worse on hilly sections due to repetitive hip flexion. It's particularly common in trail runners, and you can feel a click or a clunk of your iliotibial band as it moves over the side of your hip. This is a clinical diagnosis. There are provocative tests that can prove that iliotibial band syndrome exists within your anatomy, and stretching this or foam rolling the iliotibial band can be very effective. Then progressing to hip abductor or gluteal strengthening with clamshells or side planks. Retraining the gait so that your gluteal tendons are more fired and more turned on during the gait cycle, modifying your activities until you really regain this strength, and then gradual return to hiking, particularly a hiking distance, so building up slowly once again. Hip osteoarthritis is cartilage wear causing bone on bone contact, which can result in morning stiffness, which improves with movement, pain in the groin after prolonged activity, particularly walking, similar to FAI or femoroacetabular impingement, difficulty getting down to do your own shoes and socks, and needing to back into a low car seat because the actual movement in your hip is affected. This is a clinical diagnosis with x-rays. Treatment is weight optimization in the first instance to reduce the amount of force going through your hips, gluteal strengthening with a physiotherapist and anti-inflammatory medications, injections, or a hip replacement for advanced disease. And these have been shown to have excellent success. A total hip replacement would have you 90% recovered at 90 days, and we would hope to have you returning to hill walking or hiking with no restrictions after about 3 or 4 months of recovery and rehabilitation with a physiotherapist. With regards to the knee, patellofemoral pain syndrome is pain around the kneecap, and it's due to how the knee tracks within its groove. So the kneecap or the patella moves within the trochlear groove at the bottom of the femur, and how it always wants to go on the outside of the lateral side. And if this is the case, you can get pain at the front of the knee, particularly when walking downhill, as 4 to 8 times your body weight can go through your kneecap when you are walking downhill. You can have pain with prolonged sitting, or as the Americans call it, the cinema sign or the movie theater sign. So after a prolonged period of sitting, you feel like you have to shift in the seat in order to relieve yourself of this discomfort at the front of your knee. You can feel a grinding or a clicking sensation in the knee as it bends and straightens. And my action plan would be to avoid steep descents when hill walking if you have patellofemoral pain syndrome. Consider trekking poles to reduce the load going through your knee. Warm up, focus on your quadriceps strength, and ice the knee after activity. This is a clinical diagnosis. MRI can be considered if persistent, and the treatment would be to improve how the kneecap tracks within the groove. So strengthening the quadriceps on the inside of your knee. The VMO is the quarter of the quadriceps that's on the inside of the knee, and this can improve how your patella moves within the groove, improve its tracking, and hopefully reduce the patellofemoral pain that you're experiencing. You can tape the patella or brace it to encourage it to track more immediately or more towards the inside of the knee. And if you're having persistent problems, I would recommend a biomechanical assessment and a footwear review, as there are multiple factors that can contribute to how your kneecap tracks. A corticosteroid injection can be very beneficial to reduce the inflammation and allow you to reintroduce rehabilitation and strengthening exercises when the knee is calmed down. Patellar tendonitis is inflammation on the underside of the tendon where the patellar tendon attaches to the kneecap, or at the top of the tendon. So this is pain on the very underside of the kneecap, worse with activity. You can be stiff or uncomfortable first thing in the morning in particular. You can get a sharp pain at the start of a hike on the underside of the kneecap where the tendon attaches. However, this eases as you warm up and then returns slowly. Tenderness is also reproducible when your doctor presses on the underside of your kneecap, or you or your physiotherapist press on the underside of the kneecap and really hit that sore spot where the micro tears of the tendon are. It's a clinical diagnosis which can be confirmed again using ultrasound or more commonly MRI these days. Treatment, I would recommend rest and applying ice to allow the inflammation to come down. An eccentric strengthening program. So it's a strength and stretch program combined. So it's very important to link in with the physiotherapist. And patellar tendon strapping can reduce the amount of force going through the tendon, particularly during hill walking and hiking activities. The exercises that a physiotherapist would probably introduce would be wall sits at 60 degrees and progressing to 90 degrees with an increasing number on seconds per set, progressive loading with single leg declining squats, and gradual returning to your impact activities. Knee osteoarthritis, again similar to hip osteoarthritis, is cartilage wear causing bone on bone friction, morning stiffness, pain within the knee globally after prolonged activity, particularly walking, and also swelling and reduced range of motion that can come on slowly. Knee arthritis is a clinical assessment which will be proved or confirmed using x-rays. And the treatment again will be weight optimization to reduce the force going through your knee, physiotherapy to strengthen your quadriceps, non-steroidal anti-inflammatories, corticosteroid injections or platelet-rich plasma injections, or a knee replacement if the disease is advanced, like in this x-ray. Again, similar to a total hip replacement, I would expect someone to be 90% recovered at 90 days after a total knee replacement, and after 3 or 4 months of rehabilitation, returning to hill walking or returning to hiking with no restrictions. There are essential habits that can protect your joint and function as prevention strategies. I suppose the key principles are to progress your mileage, roughly 10% weekly increase as you take up hill walking or hiking or returning from injury. Trekking poles, particularly in the knee, can reduce the load going through your knee joint by 25%. Proper footwear with adequate support can reduce the stresses going through the inside of your knee or the outside of the hip. And maintaining a healthy body weight again can reduce the amount of force going through your hip or your knee joints. I would recommend incorporating a warm-up routine into your hill walking or hiking, 5 to 10 minutes at the start, roughly 5 minutes of level walking or light jogging in the car park before starting on the hill walk or the incline. Ankle circles, knee pull-ups, and hip rotations. So 15 ankle circles in each direction to wake up the ligaments in the ankle on both sides. Knee pull-ups to work your hip flexors, your knee flexors and your knee extensors, your quadriceps, and then hip rotations to wake up your gluteal tendons and your deep hip rotations, your deep hip rotators, doing 10 in each direction. So 10 external rotation and 10 internal rotation. I would then do some dynamic stretches, some walking lunges, some high knees, some leg swings forward and back, and some calf raises. And again, this is to increase the blood flow going through your gluteal tendons, going through your quadriceps, going through your calf, and just improving the vascularity of your soft tissues before you start on a hill walk or a hike. Cooling down then afterwards for 10 minutes is very important. So slowing down your walking to bring down your heart rate slowly, standing and stretching your quadriceps for 30 minutes each, stretching your hamstrings, so bending forward and touching your toes for 30 seconds on each leg, and calf stretching against a tree or a rock again for 30 seconds each. So stretch your quads, stretch your hamstrings, and stretch your calves. With regards to your hip and your iliotibial band, if you are engaged in a rehabilitation program for these specifically, I recommend stretching your hip flexor, which is a kneeling lunge, and pushing your knee forward. Stretching your iliotibial band, where you bring your affected knee over the knee on the other side, and you feel a deep stretch going down the outside of your thigh, and a figure four glute stretch, particularly if you need to stretch the deep hip external rotators at the back of the hip. But these are more specialized or niche stretches if these have been prescribed to you by a physiotherapist. I would seek medical attention for any of the above if the pain persists beyond about 4 weeks of rest or activity modification. It takes about 4 to 6 weeks for soft tissues to settle down. So I would recommend rest and activity modification if you do have a flare of tendonitis or bursitis. If you cannot weight bear due to the pain, if the swelling comes on quite rapidly, if you feel like your joint is unstable or you're at risk of falling, and if you've persistent pain at night or difficulty sleeping. One thing I did want to say with regards to joint replacement surgery is that it is a reliably successful option for bone on bone arthritis, which unfortunately is becoming more common as we live longer and the capabilities of the medical services continue to improve internationally. You can return to hill walking, hiking, or any sport after roughly 4 to 6 months, depending on the level of impact. There are novel techniques and technologies to aid in surgical accuracy and improve recovery. Implant longevity, or how long implants are lasting, improves year on year. It was initially thought that knee replacements or hip replacements lasted between 15 or 20 years, depending on how much activity you put through them. However, the newer generations of implants are really exceeding our expectations, and the implants that have gone in between 2005 2010 are not coming back loose. So the honest answer is we don't know how long the newer generation of implants are lasting. We're doing hip replacements through the direct anterior approach, where we go in through the front of the hip. It's muscle sparing. It passes between two nerves. We can do x-rays within the actual surgery itself, and ensure that the hip replacement goes in at 100% of an accurate position. We're now using robotic assistance to do our total knee replacements, again, ensuring that these are more accurate. We're using cementless or no cement in knee replacement so that your bone grows onto the implant and this becomes one with your bone, and as a result, hopefully would never need to be revised. Physiotherapy is always a great first line treatment, and there's an increasing menu of injections available: platelet rich plasma, hyaluronic acid, corticosteroids. I would not recommend exploring stem cell injections just because the evidence is still quite limited and they can be quite expensive. But physiotherapy and injections are fantastic, and there's no need to be afraid or apprehensive about your function after a total knee replacement or a total hip replacement, because these are improving year on year. So thank you very much for your time this evening, and I would be delighted to take any questions.
Andrew, thanks for joining us tonight. Really interesting talk. So we have a few questions coming in, so I'm going to start here. Someone's asking that they are a challenge hiker for years until December of last year. When their knee went from them, they had an MRI, showed chondrosis, subluxation, and edema. Regular loading in the gym program prescribed, but progress is very slow, and they're just kind of wondering, they've been at this for 3 months. Is that realistic, I suppose? I know you can't answer particular cases without seeing people, but just in general, what's
Mhm.
recovery time like?
Sure. I mean, edema means swelling, and that could be either in the soft tissues or the bones. And edema in the bone, effectively, if you imagine some of the trabeculae, or the kind of honeycomb bone structure could be injured beneath the surface. So it is almost like a micro traumatic or a micro fracture injury to the underlying honeycomb bone structure. So it does take a while for something like that to settle down and the associated soft tissue swelling to settle down. So that could be 6 to 12 weeks before the pain even starts to improve. And then it's all the other soft tissues around the area, the muscles, the tendons, the ligaments, the bursa, be it the hip or the knee. And there's bursas around the knee as well, which I didn't talk about in my talk, but they can be quite inflamed for 3, 4 months after an injury like that. So unfortunately, it's slower rather than rapid progress in the early stages, and then once you hopefully turn that corner, you'll find that your function really improves. But it could be 6 months before you're back to kind of 90% or 95% of what you were. The other thing is subluxation means that the bones might have moved somewhat and come back together again, and that's a significant soft tissue injury as well. So I would recommend getting seen if it's not settling, and because there could be something subtle on clinical exam that could really help the physiotherapists to help you go in the right direction.
Yeah, lovely, thank you. A few questions here on polls as well, so I'm just going to kind of group those together. Someone was asking they'd like a bit of information on the polls, and somebody else was saying that they were told by their physio to use poles to prevent falling, but if they
Mhm.
were 10 years younger, they tell them not to use the poles. So just what's the age? Is there an age limit, or is there a reason, or and where would you get them?
It really depends on your joint, on your knee, or on your hip. There's
Yeah,
in the hip, what the poles do, it stops your pelvis from tilting. So it helps your gluteal tendons, or the tendons on the side of the pelvis, so that they have to do less work to keep your pelvis moving, or keep your pelvis stable as you're walking down the hill. So
yeah,
they're very, very beneficial in the hip setting. In the knee setting, it's about reducing the amount of force going through the kneecap. I said it was 4 to 8 times your body weight that can go through your kneecap as you're descending descending a hill or stairs. So the poles will just reduce the amount of weight or the amount of force going through your kneecap. In terms of using them versus not using them, if you have good strength and dynamic stability in your knee, the recommendation will be to, not use the poles because you want to keep your knees nice and strong. But if you do have some changes on your X-rays or any inflammation on your MRI, then the purpose of the poles will be to offload those tendons and muscles that are affected. So it's kind of hard to say, is there an age cutoff? It really just depends on the status of your knee or of your hip. But if you have any discomfort or any issues or any instability episodes, I would strongly recommend them. In terms of where to get them, I'm not entirely sure of if there's a brand specifically that would be recommended, but going into a shop like one of the hiking shops, 53 Degrees North, Decathlon, and just speaking to somebody, feeling what feels good in your hands, feeling what's nice and ergonomic, what's a good height for you, get them appropriately sized, and it's more having the support rather than a particular type of brand or a particular type of material.
Okay, thank you. Great talk. How long do hip and knee replacements last? Someone's asking, and how long would it take to get back to general exercise?
It's a good question, very good question. So the older generations of hip and knee replacements we thought lasted kind of 15 to 20 years. The newer generation of hip and knee replacements, we don't entirely know how long they're lasting because they've kind of gone in the late noughties, around 2005, 2010, and they haven't come back loose or worn to the same degree that we've seen the older generation of implants. And this is because how the ceramic is engineered, how the plastic is engineered, how the titanium implants grow onto the bone. We're not using cement as often. So there's multiple factors and multiple developments that have contributed to hip and knee replacements lasting a lot longer. The technology and techniques we're using, going in through the front, x-raying hips, using robotic assistance for knees, that all contributes to hopefully the longevity of the implants as well, to the best of our knowledge. And in terms of getting back to general exercise, it's usually the kind of first 4 weeks or so is getting back on your feet, so coming off your crutches. The second 4 weeks, kind of getting your range of motion back, and the third 4 weeks, kind of focusing on your strength and your power. So anywhere between 3 and 4 months, you should really feel that you turn that corner, and hopefully you can get back to some general exercise.
Great, thank you. A few more questions coming in here as well. Let's just have a look. Sorry, my mouse isn't working. Got it. Some suggestions that the ITB band, which you were talking about, should not be rolled and should focus on building up the glutes, which some say most of the problems of the ITB arise. So I just suppose people are asking, yeah, does that make sense to you?
There's a particular test we do. It's Ober's test, OBER apostrophe
All
S,
right.
Ober's test.
Yeah.
So if you bring your knee across your other knee and you get that tightness down the outside of your thigh, that really is diagnostic that your iliotibial band is tight, and that pushes your greater trochanteric bursa against the bone, and that bursa is really interconnected quite closely with where your tendon attaches. So that entire lateral hip complex can be inflamed. So strengthening your glutes, stretching your iliotibial band, that'll really help your gluteal tendons, help your iliotibial band, and take the pressure off your bursa. So whilst a gluteal tendon based program is very beneficial, stretching the iliotibial band will really take the pressure off the bursa as well.
Okay, thank you. And one more here. Is the gluteal tendinopathy a condition that can reoccur? Can a tilted pelvis contribute to this condition?
Yes and yes, unfortunately. It really, when you do see a physiotherapist and really make kind of strides or progress in the right direction, it's about maintaining that progress. And I always tell people in the clinic that the most important time to stay on top of your rehabilitation and stay on top of your physiotherapy exercises is when you're strong and when you're relatively pain-free, to prevent a flare. That goes for back pain, that goes for gluteal tendinopathy, that goes for knee arthritis. It's really about working these exercises into your daily routine. So first thing in the morning or last thing at night.
Okay. Andrew, thanks so much for joining
Thank you
us.
very much.
Okay, thank you. Now I'm just going to introduce Dr. Kieran Cosgrave. Kieran is one of our sports medicine doctors here in the clinic. There's going to be a video, and following that will be Dr. Matt Cosgrave, who's going to talk about foot and ankle injury while walking. Thank you.
Hi everyone, I'm Dr. Kieran Cosgrave. I'm a consultant in sports and exercise medicine, and I'm the director for UPMC Sports Medicine and UPMC Institute for Health. I just wanted to take a few minutes to talk to you about what we do in sports medicine. because the name itself can be a bit confusing. Yes, we do see sports injuries and we do treat athletes, but essentially what we do is we specialise in the non-surgical management of musculoskeletal conditions, where a musculoskeletal condition is an injury to the body, the muscles, tendons, ligaments, joints or bones. We see injuries from all over the body, from head to toe, and whether it's an acute or a chronic issue, whether it's an issue from trauma or from wear and tear, and we see injuries in people from all age groups. The principles for treatment are exactly the same. You have an issue that's preventing you from being as active as you'd like to be. That goal might be high-level sport, or it might be just maintaining your independence by being able to walk to the shops. But our role is to try and establish exactly what the diagnosis is and then put in place a management plan that fixes that issue for you. The management plan will often include a rehabilitation plan working on range of motion or strength or control of movement. And it may or may not also include an intervention like an injection. All of our sports medicine consultants are trained in ultrasound guided injections. We inject pretty much any area of the body with medicines like steroids, hyaluronate, PRP, arthrosamid and Botox, obviously depending on what the diagnosis is. As well as our clinic in Santry, we also have sports medicine clinics in Waterford, Tipperary, Limerick, Cork, Mayo and Galway. You can find full details of all of our services on our website. And the good news is you can access all of our services directly without the need for a referral into the consultant. So if you have an issue that you've been struggling with and you haven't been able to get on top of it, then get in touch with the team by phone or by email. The contact details are on the screen and the team will be sure to get you booked in with the appropriate person. Good. We've worked hard over the last couple of months to get our waiting list down, and we can now see patients within 2 or 3 weeks. That's everything from me. Thank you for listening. And if you have any questions, please don't hesitate to get in touch.
Hello, everybody. My name is Matt Cosgrave. I'm a consultant in sport and exercise medicine at the Sports Medicine Department in UPMC SFC. I'm delighted to join you this evening to talk to you about foot and ankle issues that affect walking and hiking. Just as a bit of an overview of what we're going to cover today, there's a saying in medicine that common things are common. There are lots of injuries, lots of problems that can happen to the feet and ankle associated with walking and hiking, but we're going to look at the main families of injuries, and we'll cover some of the common treatment options and the pathophysiology that might be associated with these injuries. We're going to have a look at why we get injured, and then we're going to talk in a bit more detail then about how can we prevent these injuries happening rather than focusing on just treating and curing them. So what is common if we think about studies around walking and hiking and the epidemiology of injury? One of the biggest studies is from the Appalachian Trails, and it looks at respondents from over 1,300 hikers over a 6-month period, and they found that of all hikers who responded, 42% of them didn't complete their hike, with the primary reason being cited as injury. Of those who got injured, 40% reported foot and ankle injuries as the primary issue, and this was by far the highest area of injury associated with hiking. 13% reported pain in the Achilles tendon specifically. A smaller percentage of only about 4 reported issues such as stress fractures, which we'll look at in a little bit of detail later. And then there were also walkers and hikers who suffered traumatic injuries such as ankle sprains, and these might have made up about 14% of presentations. Today, however, our primary focus is going to be looking at some of the overuse injuries that patients get. So the first thing we're going to talk about is plantar fasciitis, which is one of the most common presentations of walkers and hikers that attend the clinic here. The plantar fascia is a thick, semi-elastic band that runs from the heel to the forefoot. Its primary job is to help maintain the arch of the foot. So when we stand or when we walk, gravity and the force of our body wants to push down on that midfoot, and it wants to make the arch of the foot collapse. The elastic band then of the plantar fascia stretches in a horizontal direction to try and prevent that collapse of the arch. At the heel, it's attached at 2 parts, whereas at the forefoot, it's attached at 5 parts at the 5 heads of the toes. And so for the vast majority of patients, the problem tends to occur right at the attachment on the heel. What happens over time is that you get a little bit of micro tearing or micro trauma. If we have the opportunity to rest this, then it'll usually heal. If we don't and we continue to load it and continue to walk on it, then we tend to develop scarring and a little bit of thickening and stiffening of the tissue. Then what happens is we get a little bit more traction force on the heel, and we get a little bit of bruising at the attachment side on the heel. And then eventually what can happen is some of those fibers can fail, and we can develop some micro tearing at the attachment site, and we call this intrasubstance tearing. And these can be very stubborn and quite difficult to treat. The main way we look at treating these is we look at rehabbing the foot and ankle complex. This is just a bit of a diagram or a schematic of all the muscles and tendons that surround the foot and ankle. I mean, if we think about the foot arch itself as it scrolls back round to the inside part of the foot, you can see there are a number of muscles within the foot on the undersurface that help support that arch. There are also a number of muscles high up in the calf that run down both sides of the ankle and wrap underneath the foot to try and give the foot a side-to-side stability, but also help to prop that arch up on the inside. So when we talk about physiotherapy and rehab for this type of injury, really what we're trying to do is optimize the strength in the muscles within the foot and optimize the strength in the muscles, particularly that wrap around the inside part of the ankle and help to support that arch, thereby taking away some of the work that the plantar fascia has to do. When we struggle with that, we then start to use some other treatment modalities. This is shockwave therapy. The way shockwave therapy works is it delivers sound waves to the area at a very high frequency. Those sound waves cause the cells to vibrate very quickly. That does 2 things. One is it stimulates a healing response by mimicking trauma, and the body starts to send growth factors to that area to try and heal. The other thing it does is it actually desensitizes the area, so it can actually act as a little bit of a pain relieving agent. When we do shockwave treatment, we normally recommend starting with 3 sessions. We would do 1 session at a 1-week interval, and after that 3 weeks, you should already be starting to see some improvement. I mentioned earlier that one of the problems with plantar fasciitis is that the connection of the plantar fascia to the heel bone, sometimes you're developing a bit of bruising within the heel bone, and this is the kind of scenario where shockwave can be very, very helpful. In some other scenarios, we might use injections. The 2 main injection options that we have are steroid or PRP. We use steroid injections if there's a lot of inflammation in and around the tendon, in and around the plantar fascia. And that's because steroid acts as an anti-inflammatory. It usually has a very quick onset of action, and quite often patients feel very comfortable within the first 1 to 2 weeks. The downside to it is that it only is a temporary treatment in that it suppresses the inflammation. But if we don't do the other treatment modalities, such as the shockwave or the rehab for the foot and ankle to build up the strength around the muscles to support the arch, then eventually what will happen is if you go back to walking at high mileage, you'll be back in the clinic usually somewhere in the region of 3 to 6 months later with a recurrence of pain, and sometimes even worse because you've been walking under the effects of the steroid and probably causing to some degree a little bit more trauma to the plantar fascia. The other option that we have for injection is PRP, and that stands for platelet-rich plasma. That's when we take a sample of your own blood from the arm, we spin it in a centrifuge, and we take the platelets from the blood sample and we inject those directly into the plantar fascia. The reason we do this is the platelets have a healing property. They stimulate a healing response. And so for all of us, we have our plantar fascia and our tendons in general, they have poor blood supplies. So what we're trying to do is take these healing properties that our blood has and put them in a high concentration into the plantar fascia to try and stimulate that repair and recovery process. It also has a natural anti-inflammatory effect. The downside to the injection is it can be painful. It is also much slower onset of action than the steroid injection. And so it may be about 6 to 12 weeks until you're really feeling the benefits of it, because what it's doing is it's stimulating a biological process, and we still need to wait for that to happen. The other thing with the PRP injection is because we're injecting into the plantar fascia, we're temporarily causing a little bit of trauma and weakening it. And so we normally recommend that you wear a walking boot for about 10 to 14 days after the injection of PRP, which is a little bit more restrictive than some of the other treatment modalities that we have. If we move on then, we'll look at tendinopathies. The main tendinopathies involve either the Achilles tendon, which is at the back of the heel. It's the thick rubbery substance that attaches onto the heel, and it attaches the calf down onto the heel bone. We have your tendons that run around the inside of the ankle and support the medial arch. There are three main tendons there: your tibialis posterior, your flexor hallucis longus, and your flexor digitorum. And of those three, the one that tends to give us the most trouble is your tibialis posterior, because it's the one that hooks around the inside of the ankle and attaches on the midfoot and has the main responsibility of propping up the arch. And then if we go to the outside of the ankle, you have two perineal muscles which stop the ankle from rolling out, so stop you inverting the ankle or rolling the ankle as an injury. And they wrap around the outside of the ankle and attach onto the outside of the foot, and then one runs underneath the foot. What is tendinopathy? I suppose there's two analogies that we commonly use for this. If we think of a tendon like an elastic, its job is to transfer the contractile force of the muscle to the joint and make the joint move. So if we think about the Achilles, our calf muscle contracts, it pulls on the elastic. That starts to lift the heel off the ground, and then the recoil of the elastic is actually what gives you your spring in your step. It's the same principle for the tendons that run around the inside and the outside of the ankle. The Achilles would just be much more of a power-based tendon, and it would help drive you forwards and drive you uphill. The tendons around the inside and the outside of the ankle, they're more involved in the control of the side-to-side movement of the foot and ankle. So if we're doing a lot of trail walking where the ground is uneven, the tendons around the inside and outside of the ankle are going to have a lot more work to do than if we're just walking on a smooth, flat ground. If we stick to the elastic analogy at the minute, what happens with tendons are the same that happens with elastic. If we stretch them nice and gently, they tend to work very well. If we stretch them too much or we stretch them too often, what happens is they lose some of that elastic property. And I suppose that's to some degree what's happening within the tendon. Similarly, if we don't use the elastic or the tendon for a long time, what happens is it stiffens up. And then if we go from not using it to all of a sudden try and ask it or try to put a lot of demand on it, and we try and stretch it, what we tend to find is it's a little bit resistant to movement, and that can often present with pain and inflammation around the tendon if we've gone from a period of inactivity to quite a lot of walking or hiking in a short period of time. What can sometimes happen with tendons as well is if we continue to strain or stress and ignore the signals that the tendon is giving us, we can also develop this intrasubstance tearing that we talked about within the plantar fascia. What tends to happen is if we now move to the kind of analogy of spaghetti, the tendon is made up of very thin fibers of collagen that are nice and tightly packed together. When we have tendinopathy, some of those spaghetti fibers become cooked. Now, again, the tendon is designed to tolerate tensile force. So if we have dried spaghetti and we pull it from side to side, it tends to tolerate that very well. Whereas if we have some cooked spaghetti that's a bit soft and we pull it from side to side, we can split that fiber. So when we get intrasubstance tearing of the tendon, it's not torn like a piece of paper. It's not torn off the bone. What we tend to find is that there's a little bit of failure of some of the fibers within the tendon. And what we're trying to do in treating it then is either directly treat those torn fibers, or we're trying to treat the fibers around the injured area. So we're trying to treat the healthy tendon so that it becomes stronger and it can deal with more of the added burden that's being placed on. And so suppose that takes us then into the treatment modalities, and it's very, very similar for the Achilles, for the inside of the ankle tendons and for the outside of the ankle tendons. There's just a little bit of nuance and specificity in the exercise selection that we use. So some of this might be heel raise activity, some of it might involve resisted banded exercises, but ultimately it's a strength-based program that tries to improve the strength in the muscles that are predominantly based up in the calf area and that wrap down around the back of the ankle or the inside or the outside of the ankle. When we're struggling to get headway with the rehab program, we may use shockwave therapy to the tendon or to the tendon attachment site, or we may use an injection. Again, if our primary aim is to just suppress the pain so that we can get a good block of rehab, we'll often use steroids. If there's any damage to the tendon, such as intrasubstance tearing, we'll favour the PRP or platelet-rich plasma injection. So if we move from the kind of back of the foot and ankle forward to the forefoot, there are three main issues that we tend to find with the forefoot. One falls under this umbrella term of metatarsalgia. Now, this may involve just some pain and inflammation of the fat pad at the head of our toes, or it may involve something called sesamoiditis, which is a very small bone that sits immediately underneath the big toe. Its job is to act as a little bit of a pulley for the tendon that runs underneath the foot, and it helps to strengthen the flexion of the big toe. But what can happen is you can develop some bruising and inflammation both within the bone and around the bone. Similarly, often patients who walk and hike a lot will come in and complain of pain in the big toe itself, and that's because there's often a lot of movement at the big toe, and that movement over time can translate into some arthritis change in the toe. If we move over to the second image, what we're looking at here is what we call a Morton's neuroma. So pain in between the toes either presents with pain that we feel in the forefoot, or sometimes a numbness and tingling. And that numbness and tingling is because a neuroma is essentially a thickening of the nerve that runs between the heads of the toes. And sometimes if we walk a lot, or if we wear tight-fitting shoes, we can get a bit of compression of that nerve, and it starts to swell and it develops something called a neuroma. That neuroma can simply give us pain, or it can give us some sensory change in disturbance in the foot as well. Moving on to the third image then on the right, what we're looking at here is essentially what we would see on an MRI of a patient who has a stress fracture, or what we call a bone stress injury. When we're loading the bone, we expect the bone to heal. If we don't give it the opportunity to heal, then what happens is the bone structure starts to break down a little bit. You develop some bruising in the bone structure, which is what we see in the image here in the second toe, that bright white color. The beauty of an MRI over something like an X-ray is that often X-rays will miss stress fractures, especially in the early stage. And so MRIs are much more useful and much more sensitive for picking up bone stress injuries and stress fractures. When we think about treating these types of injuries, again, they all fall into a fairly similar pattern. If we park stress fractures for a second, I'll come back to that in a minute. But if we look at metatarsalgia, sesamoiditis, Morton's neuroma, or something like an intermetatarsal bursitis, where we get pain that almost mimics a neuroma, but there's no neuroma present, what we want to do is we want to try and provide as much support around the foot as possible. That's the first step. Something with a stiff forefoot, so a shoe modifications is where we usually start. And a stiff forefoot is something that's going to give us minimal toe flex, and that's going to allow the force that we translate on the step to almost rock through the bottom of our foot and let us spring off the toes rather than getting a lot of bend or flex in the toe area. If we're unsuccessful here, we might use some custom fit orthotics. When we think of custom fit orthotics, we can break these into two. We have the lower spec, which might be off the shelf that we can mold, and there's a service that we offer here in the clinic where we can look at your foot shape, we can look at the issue that you're dealing with, and then we can mold and fashion what's effectively an off-the-shelf orthotic to provide a bit more support around your foot that's specific to you. The higher tech version of this is where you would go in somewhere and you would get something like a 3D scan of your foot, and then you would get a bespoke hard orthotic that's molded perfectly to your foot size and requirements. The difference between the two is the off-the-shelf version is a little bit more malleable, so you can make changes to it more readily. The second benefit is in terms of cost. If you're thinking about getting something like a custom fit orthotic, you could be paying somewhere from €300 upwards, whereas something like an off-the-shelf orthotic can range from €30 to €100. The benefit of getting something like a custom fit or an off-the-shelf orthotic with us in the clinic here is that we can tailor the needs specific to you, and we can also look at some of the rehab needs of your foot and ankle at the same time as fitting any orthotics. If we go on then to look at bone stress injuries in a little bit more detail, I just wanted to give you a sense of why bone stress injuries and stress fractures happen. Essentially, there's a constant continuum, largely between healthy bone and bone stress. And we know this because there's been some real great studies done on triathletes who have run for or who have performed in a race, and after they've raced, we've scanned them and they've had quite prominent bone stress in a number of areas. Now, they're totally asymptomatic of this, and after a few days rest and recovery, a lot of that bone stress recovers. Now, if we know that process is happening when we apply stress to the bone, if we don't get the signals from the bone and we're not allowing the bone periods of time to rest, then eventually what happens is we start to develop a bone stress injury where we start to get pain with it. When you reach that bone stress injury phase, the recovery time just takes longer. If we ignore the pain and continue to work, we'll eventually develop a stress fracture, which is a small crack in the bone. It doesn't necessarily break, which is what happens when we have a complete fracture, but it cracks. And again, the implication of that crack is that it just takes much longer to heal. The only way really to treat these is to take away the insult. So take away the stress that is causing the problem. And for most people, that will involve either going into a walking boot for a period of time, or depending on the site of the injury, it may involve going non-weight bearing, which might involve using crutches for a period of 4 to 8 weeks, depending on the issue. So why do we get injured? I suppose ultimately it comes down to the idea that the demands that we're placing on the tissue, be it the bone, the tendon, the muscle, the plantar fascia, are exceeding the capacity of the tissue. It can be affected by a number of things. One is just the underlying strength and quality of the bone and tissue. And as we age, what we tend to find is that the strength and the quality of the tissue reduces. So age in general does play a part in this, but these are not all age-related injuries. And despite aging, we can often do plenty of work in terms of building up and developing the strength around the tendons, the plantar fascia, the ankle, the foot, and even the bone that can reduce your risk of injury going forward. Sometimes it can be down to your biomechanics, so essentially how you're moving, what way your foot and ankle is shaped, and how they move when you plant on the ground, and how they move as you walk and hike. Similarly, problems in the foot and ankle can originally stem from issues higher up through the knee or the hip, or weaknesses higher up in the knee or the hip, because ultimately when we walk, there is a kinetic chain that has to do the work to get us from A to B, and if we have weaknesses elsewhere in that kinetic chain, increased demand and burden can get placed on the foot and ankle. Training errors is a big issue, and I'll go into that in a little bit more detail. But essentially what training errors refers to is how we approach exercise and activity, how we ramp up that activity or increase it, and at what rate we do that, and how we approach activity having had a period of downtime. Equipment errors might involve things like footwear, old footwear, weathered footwear that maybe has lost a bit of its structure and support. And then similarly, footwear that doesn't really fit your foot shape or size, something with a narrow toe box that's possibly giving you some metatarsalgia or contributing to Morton's neuroma type pain, for example. Similarly, we may want to use equipment to help reduce the burden on the feet and ankle, and it's understanding when we need to do that, and that might involve something like walking poles or crutches. Underfueling is a big issue, and we see this more and more, and it's something that we're becoming more and more aware of. And essentially what underfueling refers to is nutrition. So if we're going out and exercising, especially if we're going out and doing 2 to 4 to 6 hour hikes or walks, are we getting the right nutrition into us to fuel our bodies, to fuel our tissues for that walk? And that goes back, that's not just on the day of exercise, but how are we approaching it throughout the week in the build up to that activity? We wouldn't run a marathon without preparing, and often people refer to this as carb loading, and there are different versions of this, but essentially what we're trying to do there is we're trying to provide enough energy and enough fuel for the body to meet its demands, and the same thing applies to any activity we do, especially longer walks and hikes. Finally, then we think about things like external stressors. How busy is life? How well rested and recovered are we? If things are stressful, we're not getting enough sleep, if we've had recent illness or recent injury elsewhere, our likelihood of getting injuries in the foot and ankle significantly increase. So if we think about why we get injured, and specifically training error, there's this terrible twos that people often refer to. Essentially, too much activity, too soon, and too fast. So too much activity applies to the overall volume. So how many miles, how much time we're spending on our feet, and is our body prepared to do that? Too soon often refers to our return to activity after having a period off. So if we think of the spring as being the highest risk period for foot and ankle injuries and for injuries of walkers and hikers, that's because we've usually had a period of inactivity over the winter, and then all of a sudden we've rapidly wrapped it up when the good weather starts to return. And that's significant. That's one of the significant issues that people find, is that they haven't given their body enough time to adapt, and so their return to activity has been too soon, especially after a period of time off. That's similar for the too fast. We might come back to activity and feel great really early on, but we might increase the intensity or the demand too quickly then. It may be a case that we go from walking on the flat to terrain or high incline walks in a very short period of time. But the principle is starting slow and giving the body time to adapt over a longer period of time rather than a short period of time, and listening to our body for signals, listening to the foot and ankle for any signs or symptoms of pain or stiffness, and that tells us that we usually need to taper back on things before we can then build on that again. How do we approach this then, and how do we try and reduce the risk of injury? I mean, the first thing we've got to ask ourselves is, what is our baseline? Are we a seasoned walker or hiker? Is this something we've been doing on year? Or is this something that we're just wanting to start off afresh? The more chronic exposure you've had in years past, usually the better capacity your tissues have to tolerate the demand. But then similarly, I mentioned it about the spring being the high risk period. What have you been doing over the winter period? If you've been very sedentary, you're going to need to take things low and very slow at the start and gradually build it up. Whereas if you've been active in other areas, such as the gym, using other equipment outside of the walking, then the likelihood is that you probably don't need a very long time to adapt. And you can usually pick up where you left off, or at least get back there within a reasonably short period of time. What is it that you want to achieve? Are you walking for a specific event that you're preparing for? And if you are, use that as your endpoint and gradually build yourself up there. Think about it in terms of, how much do you want to achieve in a week? How much do you want to achieve in a single walk? It may be a case that you just want to walk 30 minutes a day, 5 days a week, and that's very achievable. But your approach to that should be something like starting off at 10 to 15 minutes a day initially. And usually at the early phases of walking, we would suggest that you start with an alternate day basis so that you have that opportunity to recover. And once you're meeting your milestone on an alternate day basis, then if you want, you can start to introduce that activity on the day in between. For most walkers and hikers, the weekend is the milestone, and it's important that we remember that just because we're doing that one walk on the weekend doesn't mean that we should do nothing the rest of the week. Because actually, if we provide some stimulus to the tissue throughout the week, then we're much less likely to get an injury from the big load that we're applying to it on the weekend. Whereas if we do very, very little on the weekend during the week and a lot at the weekend, our body struggles to adapt to that in a very short period of time. And that's actually much higher risk of injury than keeping things ticking along during the week and then just a small jump at the weekend. So just keep that in mind for those of you who like to do your longer 2 to 4 hour walks at the weekend. And then how do you get there? I suppose one is just gradually increasing the volume and the mileage, and think about it in terms of either the distance, the time on feet, or the time of the walk, but also use things like a pedometer, a watch that might track your steps, and just keep an eye on what your average step count is throughout the week. You can also break it down into days, and you can highlight the days where you walk and the days where you maybe do your longer walks. Similarly, think about the surface that you're walking on. If you're starting off or if you're just returning, flat surfaces are optimum, flat and smooth. We then might start to introduce an incline and decline, and then we can start to introduce some of the rougher, more unsteady terrain that's going to put more strain and stress onto the tissues. So as a little bit of a summary, we want to talk about building volume. So alternate days, maybe one longer walk at the weekend. Start flat, then hills, then build into terrain, and then monitor your load. And you should be able to track this fairly easily. And when you're able to track it, you'll be able to say, okay, is there a day of the week, or is there a week that has been a significant outlier to the level of activity I've been doing elsewhere? And it often gives you a really good indication, and it often gives you a very early sign of where you might have a potential of injury long before any of these problems can happen. I'll talk to you in a minute about the 10% rule, but that's something that some patients like to apply if you're keen on numbers and you want a little bit more detail to quantify your build of load. But the other thing that we think of is our general preparation. And this is where the likes of physiotherapy, strength and conditioning coaches, physical personal trainers can come in handy. And even sometimes if your access to those sort of services are poor, there's lots of options and lots of resources on the likes of YouTube or other social media channels that can help give you a bit of direction around how you should be building up the strength, how you should be building up the function and the resilience of your foot and ankle. At the clinic here, our strength and conditioning coaches offer a service that we can look and get some measures of the strength around the foot and ankle. They can provide you with an exercise program, and they can also provide you with some programming around building up your walking volume, especially if you've got a targeted goal or event in mind. Nutrition, for most people, it's really just a case of making sure that we are getting all our macronutrients, a good balance of carbohydrates, protein and fat into our diet, and making sure that we've got good quantities of food that would be enough to fuel our bodies for extended periods of exercise. We do have access to a performance nutritionist. We don't have, there's a few, that work within the clinic here. And if any patients want a direction to those, we'd be more than happy to provide that. And we can be able to give you a little bit more direction around specific nutritional needs and a bit more education around that. And then finally, equipment. And that's thinking about things like footwear, orthotics if necessary, and then walking aids such as walking sticks. And finally, I'm just going to finish on this idea of the 10% rule. And this is largely adapted from running, but patients will often use this we'll often use this in the clinic, for patients who are returning from things like stress fractures or from foot and ankle injuries. The basic concept is that we want to reduce our total weekly volume increases by less than 10% week on week. So if our usual walking volume is 1 kilometer a week, we would want to try and avoid walking more than 1,100 meters the following week. Now that's a very small number, but if you extrapolate that 1 kilometer a week out over 5 days, and we say that we walk 5 kilometers a week over the course of the week, we would really want to be keeping our increase the next week to be less than 500 meters in total. As I say, it tends to be better for larger volumes, and that's why it tends to be better for those who run. But more recently, there's been a little bit of refinement around that advice, and there's been a study that was produced in the last year that has found that actually the highest risk of injury occurs in patients who increase a single session activity of more than 10% than any previous walk or hike that they've done in the last 30 days. So for most patients, this is the highest risk period in that first month or that first 30 days that you've done. If you can gradually build that activity level up to your baseline, then that means you've got much more wriggle room in the months ahead, where you don't have to worry too much about small spikes in activity as long as they're no more than that 10% increase on your previous longest walk or hike in the last 30 days. I hope that was helpful. I'm more than happy to answer any questions and clarify anything that maybe was a bit unclear there. Thank you.
Great presentation, Matt, and a lot of questions coming in, so we'll kick off there. I have moderate osteoarthritis in my first NTP joint in my big toe. Any particular treatment for pain and healing?
Yeah, so first MTBJ or first big toe arthritis is something that we would very commonly see here at the clinic. I suppose you would start off with standard treatments, which would be oral anti-inflammatories. That would be probably kind of the most obvious, which you could buy over the counter. If that's not controlling things for you, then you might think about some injection options. And first line option injection-wise would usually be a steroid injection. We do use PRP injections for these sometimes as well. but the steroid tends to be the first line. It's got more evidence behind it and usually more effective.
Okay, good, thank you. Can you see any benefit in hiker hill walkers wearing compression socks, as do long distance extreme runners and athletes wear?
The same principle of thought behind them is that they will improve the venous return. So in other words, improve the blood flow back up from the extremities to the central system, and therefore improve the recovery of the muscle, and improve the muscle's ability to work for longer, thereby being able to walk further and more comfortably. So the same principle would exist for walking as it would for running or any of those other endurance activities. There's certainly no harm in trying them. How much benefit you would get is sort of person dependent, but it's definitely worth a try.
Okay, thank you. Do you think you can get back to big climbs following a Lisfranc injury?
Well, a Lisfranc injury is a pretty significant injury. It's definitely possible. We'll treat lots of athletes who'll get back to high-level international sport having had Lisfranc injury. I suppose it's a little bit difficult for me to comment on that, not knowing the full extent of the injury and what was done for it. I would always recommend, if you've had treatment for it through, say, a surgeon, that you speak to that surgeon for advice on where they feel your level of activity should be. But we would definitely be aiming for getting back to some level of activity, and it's certainly achievable to get back to higher level function with it.
Okay, thank you. Great talk. Thank you. Is the tip of rolling a tennis ball under the foot a good idea if plantar fasciitis pain starts on a hike?
So the short answer is yes. I thought about talking about this during the talk. I suppose when I started training, that was the kind of general advice that we were taught. And it does help. It can definitely improve symptoms. It's massaging the plantar fascia and massaging the tissue around it. And it does provide a little bit of loosening to the tissue, and it allows it to be a bit more pliable. It also desensitizes the area a little, so it can make it feel more comfortable. But really, it's a short-term treatment option. It's really you're treating the symptoms rather than the cause. And you may get short-term temporary relief from it. And if it's a case where you walk, you massage the foot, it improves things, and you're able to continue on that kind of pathway, then that's generally fine. But if you're finding that it's taking more and more to control the pain, or the pain's not actually going away with it, although it's desensitizing it a little bit, then you probably need to be looking at a more definitive treatment option.
Okay. And again, on the plantar fasciitis, someone says, does it help to continue exercising if it hurts?
Yeah, so we rarely tell patients to stop entirely, because we do want the foot to continue to work. We want the muscles in the foot and the muscle around the ankle and the calf to work. It really depends on your level of symptoms. We sometimes use a pain score where we say 0 is no pain, 10 is agony, can't put the foot to the floor. And we would normally say that something in the region of about 4 out of 10 is a good barometer for where it's safe to continue. Going above that, you're probably causing more problems than than you're helping. Whereas if you're below that 4 out of 10 level, generally speaking, you're okay to continue to walk. Rather than a kind of walk or not walk, what it's usually an indicator of is increasing or decreasing the volume or the intensity of your walking. So as your pain's reducing, you can then start to increase the volume or intensity of your walks. And then the contrary would be, as your pain's increasing, you want to be reducing the volume. And if you're getting to a stage where you're struggling to get out of bed in the morning, struggling to put the foot on the floor, then really you probably need a period of rest where walking is at a minimum, just to allow it to settle down. And that if that's not improving things, then you need to start thinking about other treatment options.
Okay, thank you. Some people asking here about trainers for the Camino. Are some with a little more heel to sole ratio better for withstanding forces, as some seem rather flat? And there was another question somebody asked as well about the best type of shoe and boot to wear when walking or hiking to prevent falls and slips.
Yeah, so I suppose the disclaimer here is that this is not an area of expertise for me. terms of footwear and podiatry. Really, you want to speak to a podiatrist to get an idea of what is the best fit and shape for your foot, or go to a good hiking store or a good athletic apparel store where they'll be able to provide you advice on the different options to you and the different options that would be most suitable to your foot. It's very individualized, and it really depends on what your foot shape is like, how your foot moves, and then any other issues that you've maybe had with your foot at any, or foot or ankle at any time in the past, because that to some degree will dictate what boot preference or shoe preference you're going for as well.
Okay. What's treatment for anterior tendon lower front from shin onto the foot? Any?
Yeah, that sounds probably like a tibialis anterior tendon, and it's a very similar sort of treatment process as we would do for any of the other tendinopathies. We're looking to reduce the high burden or load or stress that's on the tendon, and we're then looking to try and strengthen it up through first slow controlled loading of the tendon and then gradually increasing the volume and intensity of that. Similar to the other tendons, there are other treatment options such as shockwave therapy and injection of steroid or local anesthetic, depending on what the exact details of the injury or the issue are. It gets treated under that umbrella of tendinopathy, and it's something that we would see quite common as well.
Last one now. Somebody here, they've been quite active doing 10K a day and long hill walks with plantar fasciitis for over 7 months. They've been doing the exercises, had some shock treatment, but they still have the pain, and they've reduced their walking to 6 kilometers. They're really just saying, what should they explore next?
So yeah, if you've tried all those options and you're still symptomatic, normally what we would want to do is get a picture of what the plantar fascia looks like under imaging. So we would recommend an MRI. What the MRI will tell us is what is the quality of the tissue, how thickened is the tissue, is there any evidence of intrasubstance tearing, and then with that information in mind, we can then kind of direct the treatment pathway. And more likely than not, if you've tried shockwave therapy, you've tried rehab, you've tried load modifications, you're probably looking at some injection option at that stage.
Matt, thanks very much for joining us tonight, and thanks for everybody who's joined us. If you want to recommend this to anybody, it will be on our website to watch in a day or two as well. We will be sending out an evaluation. If you could complete that, it really helps when we're planning our next talks. Just to remind you, there is a tab there for health screening if you're interested in health screening and fitness screening as well. And if you want to book an appointment with anyone who's spoken tonight, or you have any other questions, or about any other surgeries or musculoskeletal conditions, please feel free to go on, book an appointment, and we'll help you there. Just to let you know, part of the group, it's not here, but on the UPMC network, there is a talk on the 26th of March on urology, which again will be a webinar. If you're interested in that, you can register. Thank you again for joining us tonight.